So, good evening, everyone, and it's always a pleasure to welcome you all to our masterclasses. So, all of you, welcome to yet another masterclass by Dr. Abha Majumdar on oocyte cryopreservation, the medical and social indications. And she's going to talk about new era in fertility preservation. So, let's learn from ma'am once again the nitty-gritties of oocyte cryopreservation. Over to you, ma'am.
Thank you so much, Tejashree, for always being there, and Vishal for giving us this platform where we can um, sort of give lectures, invite questions, and resolve all our queries regarding one or other topics also. So today the topic is oocyte cryopreservation, and we'll talk about the medical and social, both indications of cryopreservation. And this is a new era in fertility preservation. So having said that, I wanted a little screen of my view that I could see. How many people have joined by now?
22 have joined, ma'am.
Okay. So I think it is enough number to start. Bhavani has also joined. I'm so happy. I thought she's not joined yet. So where did my screen go? I'm so sorry. Do you see my screen?
Yes,
Yes,
मैम
ma'am.
स्क्रीन दिख रहा है बट पावर पॉइंट बंद हो गया आपका.
हाँ, PowerPoint नहीं है ना? Even my PowerPoint went away. Yeah, I'll do it again.
ये सेकंड लास्ट वाला है ना मैम. फर्स्ट हाँ अब आ गया.
Now you can see it?
यस
Can you
मैम.
see me also?
यस मैम. यस.
Is my face visible? I can't see anything. I'm so sorry about this, but
Any your face is visible.
okay.
Face is also visible.
All right. Thank you so much. So, indications of oocyte cryopreservation, as we all know, they could be medical reasons, and we all understand this since quite some time, maybe 15 years or even more, that cancer patients undergoing chemo or radio, this we're talking about women only, though men also have medical reasons, but oocyte cryopreservation is with women. And if a 25 or a 30-year-old girl is suddenly diagnosed with some type of cancer which requires chemo radio, then we know that this can reduce ovarian reserve very dramatically, and hence they like to preserve their fertility beforehand. And there are certain girls who know that they have a low ovarian reserve, or they should know that if they have autoimmune disease or a genetic problem with other siblings or endometriosis, then all these, and especially if they have had surgery for endometriosis also, can lower the ovarian reserve and lead to the need for fertility preservation. Then emergency reasons we see in our IVF practice. Sometimes the male partner is unable to give semen on the day of oocyte pickup, whether it is mental stress or some type of ejaculatory defect. But now, to overcome this, we always like to preserve a semen sample. We ask all the men when they start the IVF cycle, do you think you can get sort of a problem in giving a semen fresh? We always test one semen at our center, and we ask the person if he wants to preserve it, so that on that day, if he's unable to give, we do not have to resort to oocyte cryopreservation, or do not have to resort to TISA-like processes, which we do, because electroejaculation we still don't do in our center. Very few people must be using electroejaculation to get ejaculated sperms. But if you don't have these facilities, then TISA becomes the last choice unless you preserve all oocytes. And the most important indication which is now emerging is social egg freezing for fertility preservation for future use and childbearing. So we'll talk about medical egg freezing. And the most important thing in medical egg freezing is that you should start immediately. Patient may come on any day of her cycle. She may come, I mean, rarely they may come on day 2 or 3, but they may come on day 6, day 8, day 12, day 16, day 20. So you can do a random start. You just start gonadotropins, and we know there are many follicular waves which are there in a woman's cycle. 3 mostly known, 2 are definitely there. So if you start gonadotropin, wherever the antral follicles are, from there they will start growing. Maybe one follicle will grow faster, which has already been selected and which is destined to ovulate. Let that ovulate, let that happen. But at least your next cohort is growing. According to that cohort, you can either use antagonist to prevent premature LH surge for the next cohort, or you can use a PPOS program. PPOS is more effective if the patient has already ovulated and she comes to you on days 17, 18, 16, 20, and you see that ovulation has happened, you do a serum progesterone that is elevated, you can start PPOS protocol from there only. And if the cancer is estrogen dependent and requires low estrogen levels like endometrial cancers, ovarian cancers, breast cancer, then with conventional stimulation protocol, we must add letrozole. And the lowest dose is 5 milligram, which you must start with to keep the estrogen levels very low during the stimulation. And every 5 days, after 5 days, when she comes, if you feel that you need to increase the dose, you increase it to 7.5. You can go up to 10 milligram daily. The main aim is to keep serum estradiol levels to less than 250 because she has estrogen sensitive cancers and we don't want this fertility preservation cycle to increase even one cell of her cancer. The last is adding low molecular weight heparin. And this is done when there is a prothrombotic condition associated with these cases. And very recently, I had a case of red cell aplasia, for which they said that right now she is on all type of immunosuppressants. So they said you can preserve your embryos, and then for her the regime is going to be we will start from day 2 only because she's doesn't have a need for radio or chemotherapy, and letrozole 5 milligram with the gonadotropin appropriate to her AMH and low molecular weight heparin, weight appropriate, will be started for her. Social egg freezing, on the other hand, is much more easier and it is less taxing. This refers to a process of freezing a woman's egg to preserve her fertility for future reproduction at an age when her natural fertility may have significantly declined. And here we can do it with standard conventional protocol starting from day 2 or 3, unless the woman has come in a time frame to you, and then you need to do a random start for her. Look at this case. Anita, a 29-year-old young girl, was sent to India by my friend to live with me for 6 months. She was obese and wanted to learn Indian culture and ways of living. No plans of getting married in near future. Was working and wanted to initiate a startup for Indian jewelry. I, being a doctor and gynecologist, and as she was staying with me, got her general investigations done for her health issue and also a fertility checkup done, which included a pelvic scan and AMH. Her AMH was 0.8 nanogram per ml. Now, what options if she wants a family after 5 years or even later? She's only 29. So please understand that ovarian reserve can be low for anyone, whether she's of Indian origin, Caucasian origin, whether she's obese or she's thin, whether she knows that she has an autoimmune disease or she does not know, whether she has a genetic condition underlying or she does not. But this can happen. So I feel that, when girls are reaching 30, one pelvic scan and one AMH is an important, essential investigation in today's world where women are independent, they want to be empowered, and they want also to be empowered regarding their fertility. So these two things will at least tell them that they have no major conditions in the pelvis like endometriomas, endometriosis, large fibroids, and their AMH is reasonable, so that we can just reassure them that you are not the one. If you are planning a family in the next 1 or 2 or 3 years, you don't need preservation. What really happens, late marriages are common, but problem is when they are still young and the ovarian reserve becomes low. And for young girls, it is a big blow to know that time is running out for them. And such girls need to be handled with care and lot of counseling skills. We cannot be blunt to them and tell them that, see, your reserve is you are going to become menopausal. That's a very harsh word to be told. So we can just tell them that your cycles are still regular, your reserve is less. Have you any plans of marriage? So we have to very tactfully deal with them. And especially if the girl is a smoker, if she's obese, she does vaping, and if she's got history of chronic infections, and even infections like hepatitis B if she's had in the past, or tuberculosis, or any other chronic infections, and autoimmune diseases if she's a patient with rheumatoid arthritis or diabetes, juvenile diabetes. All of them tend to lower their ovarian reserve much faster, so must be investigated in their late 20s. So why is there need for social egg freezing? At first, the age at first delivery is continuously rising. It is well known that age is the most important indicator of fecundity. There is no known treatment to avoid or reverse age-related natural decline in fecundity. So please remember, it is not AMH, it is age, which is the most important indicator of fecundity. If your cycles are regular, and even if your AMH is 0.6, 0.7, 0.8, you will still conceive because the cycles are regular and you are ovulating every cycle. Societal changes, women empowerment has led to narrower gender gaps in career opportunities, which in turn have led to changes in reproductive choices and a tendency towards delayed childbearing. Social egg freezing, which is planned oocyte cryopreservation, can give women an opportunity to extend their reproductive lifespan and time to fulfill educational and career aspirations as well. So, if we look at age and oocyte quality, less than 35 years, the mitochondria function is extremely good, whereas after 35 years, it goes quite low. So, mitochondrial function, apart from that being impaired, granulosa cell apoptosis increases, and there is oxidative stress. As we age, every cell has more oxidative stress, including the oocytes which a woman makes. And then age is another factor which can reduce ovarian reserve. Normally, with age, the ovarian reserve goes down, but there could be exceptions to this. Sometimes, even at 40, the reserve may be good, but quality definitely will be affected by age. And in her 30s, the AMH levels start declining more after 35. And as I told you, factors like genetics, ask the girl when did her mother become menopausal, or is she still menstruating, whether if the girl is very obese, if she's got a medical history, lifestyle can also influence the ovarian reserve. And this is Sandro Esteve's chart where they said that on an average, if a girl is less than 35, even 6 cumulus oocyte complexes will give us 2 blastocysts, and the euploidy rate being 60%, we will at least have 1 euploid blastocyst in this. So you understand that how many would you want if you want to preserve her fertility. And this is when the partner's sperm is compatible, and out of 6 COCs, she can make 2 blastocysts. Sometimes with a lot of COCs also, one cannot make 2 blastocysts. So for the calculation purpose, if she's 39 to 40, in which a lot of girls come for egg preservation, you need 10 oocyte complexes to make 3 blastocysts with a euploidy rate of only 30%. Out of 3, 1 would be normal. And after 40, the 5 blastocysts, 1 would be euploid. To please understand that the euploidy rate goes on decreasing as age goes above 35, and the number of cumulus oocyte complexes required is more and more for every age group. So in a age of 42, 43, even if we have 16, 20 oocytes and we make 5 blastocysts, say these eggs turn into very good blasts, you need a very good laboratory also. You cannot go to a very low performing laboratory where the implantation rate is less than 50% or the blastulation rate is low, and then expect that your eggs will give rise to very good blastocysts. Only when you make so many good quality blastocysts, you will have only 1 euploid blastocyst, which will result possibly if it implants, if the implantation rate is 50, 60%, it implants and it can result in a live birth. So you understand the need for number of eggs, even later on when you want to convert them into a embryo, a blastocyst, and a live birth, how the numbers go on increasing with age. So as time is ticking, there have been ethical arguments in favor of social freezing, which says it enhances reproductive autonomy, reduces pressure to find a partner, precludes, girls start getting very worried when they don't get married by 32, 33, because they all understand that the reproductive performance may go down. It also, once, if you have social egg freezing, it precludes the need for donor oocytes if spontaneous pregnancy does not occur. You at least have your own eggs, your own genetic child, if your eggs perform well at an age when you want them to make an embryo and get pregnant. May improves women's ability to organize their education, work, family with less pressure from their biological clock. On the other hand, ethical arguments against social egg freezing is interventions are too physically invasive with no immediate threat to infertility. She may have a good fertility potential. She's just 31, 32, and she goes in for egg freezing. So it is physically invasive. Limited success rate as age and quality impact outcomes. So please, if social egg freezing is to be done, please motivate girls to have it by 35 years of age. Efficiency of the lab, freezing the oocyte impacts the live birth outcomes later. So the same lab where the oocytes have been preserved, say if the post-thaw rate of survival of oocyte is 98%, you will get at least 8 oocytes out of every more than 8. Sorry, out of every 100 oocytes, you would get 98 oocytes. Embryo post-thaw is about 99%. If you preserve 100 embryos by freezing, you will be able to thaw at least 98 to 99, which will be growing embryos. Shelf life for cryopreserved oocyte and long-term safety for offspring is yet non-known, even though the ART law, as well as all over the world, it is understood for 10 years oocytes can be cryopreserved. But we still know less about this technique, which is not so old. And it may also provide a false sense of security to girls, and they can just go on and on. You have 10 oocytes preserved. You can go up to 45 and then think of having a baby. And this could be something which could be misleading for that girl. And when later on she thaws her eggs and they find that they've got just one blastocyst, even though it was at a young age, it could be euploid, or they've not made any embryo, then it becomes a very painful situation. So egg freezing process is exactly like when you do IVF. You start with initial consultation, day 1, 2. You start injections, ovarian stimulation, monitoring. Day 11 to 13, you've given your trigger shot. Day 14 is the egg retrieval. And here I would show you this, that once eggs are retrieved, then mature oocytes are identified from all the retrieved oocytes by the embryologist. These oocytes are frozen by the procedure of vitrification to temperatures of minus 197 degrees centigrade. Oocytes are frozen in cryopreservation straws in groups of 3 to 4 per straw, 3 to 4 oocytes per straw. And then frozen eggs are stored in specialized tanks at ultra-low temperatures, like I told you, and regular monitoring of storage conditions to ensure the viability of frozen eggs. So oocyte freezing timeline and cost. One cycle of stimulation and freezing requires 12 to 14 days of starting from day 2 of a woman's cycle. For women with low reserve or advanced age, more than one cycle may be required, which can be undertaken as following. We can have either 2 stimulations in the same cycle, one follicular, one luteal, or we can have 2 separate stimulations in follicular phase. Cost of one cycle at our center is about ₹1,00,000, which includes all hormone testing, ultrasound monitoring, oocyte retrieval under GA, and oocyte freezing for 1 year. Drugs for ovarian stimulation may be different for different patients. They may be as low as 20, 30,000 to as much as 70,000, depending on the ovarian reserve. And renewal charges yearly are approximately 10,000. So if you have to preserve them for 10 years, or 2 years or 5 years, depends. You can always go on renewing every year till you think now you need them. So this is about egg freezing in Gangaram Hospital. We started oocyte cryopreservation in 2008 for the first time. And if you can see number of patients, it was a very small number of patients. And we also had our first baby by frozen eggs in 2009. However, we introduced social egg freezing in 2016, just about 4 years before Corona, and 2021 went quite wasted. But 22 again we started picking up, and now this is only data till 24 March 31st. If we go on 24, 25, 26, then social egg freezing has gone up in numbers. This is like 35 patients. Now we are doing every month about 2 to 3 patients of oocyte cryopreservation. So it takes the numbers to, I would say, 2 to 3 or maybe 4 patients every month would take the number to about 50 per year. However, this is analysis of 86 patients only. And one of my fellows, Dr. Nitisha, did a follow-up survey on reproductive attitudes and experiences of women who underwent social egg freezing at Gangaram IVF Center. And she made a questionnaire, and from that questionnaire, the answers which we got were like we found that most of the women, minimum age of patient was 27, maximum was 44, mean age was 35.34. So if you see, out of those patients, 36 belong to 31 to 35, and 40 belonged to 36 to 41. 3 patients were between 41 to 45. So a lot of patients come to us after 30 years. 1,249 eggs were retrieved in total of 115 egg pickup cycles. And if you see, 59 had 1 cycle, 25 had to go 2 cycle stimulation to have the egg, which was in their mind adequate. And 2 patients also went through 3 cycles of stimulation. Egg retrieved per patient, the minimum was 3. But egg frozen per patient, the minimum was 1, because if they are immature, they are not frozen. Maximum number of eggs were retrieved 28, and 26 were frozen. The mean number was 14 and 11. Now, how did we do this follow-up? A questionnaire was developed, and it was administered to women who underwent social egg freezing from 2016 till 2022. We needed a 2-year follow-up, so we could not give it to patients who went through social egg freezing in 23 and 24. And there was very little egg freezing in 20 and 21 because of COVID. And then this questionnaire was sent, and then after that, if they did not answer back in a stipulated time, they were telephonically contacted and questionnaire was asked. Now, I've just taken few points over here, that some of the points were education, employment, source of initial knowledge about oocyte cryopreservation, were you married or not? Are you married now? Any natural pregnancy before oocyte cryopreservation or after oocyte cryopreservation? And why have you not used your oocytes, and how secure do you feel? How do you estimate that you will use these oocytes in the next 5 years? And do you regret freezing of your oocytes? So look at the answers which we got. Education, we found that all the girls were educated at least graduation, and these are post-graduation was done by a few, 26 patients who answered the questionnaire. Most of them were employed. So employment and education makes them aware about the process. Initial knowledge was either media, friends or family, health professional, which is almost equal always. Then why have you still not used your oocytes? Lack of suitable partner has been the biggest answer. Rest was focusing on career, trying to conceive naturally. Both 1 and 2, that is focusing on career, lack of a suitable partner, and the last was any other causes. And others I'm not thinking about kids. Why the rush? I have time. I have frozen eggs. I don't know if I want to have kids now. Not ready for kids at the moment. So having said that, we asked also, this was one of the questions, how secure do you feel about your future fertility because you have your oocytes frozen? So half of them felt very secure, others felt moderately secure, and a small percentage said they did not feel secure at all after oocyte freezing. But then when the last question was asked, do you regret freezing your oocytes? All of them said they don't regret freezing their oocytes, that they have no regrets. So even if they never use them, they don't regret freezing of their oocytes. So now what is new in egg freezing? It is elective embryo cryopreservation. What is it? Married couples are undergoing IVF only to freeze their embryos and delay childbearing. A lot of married couples are coming these days and they say, please freeze my embryos and I will come after 2-3 years to have a child. We have plans right now. Some couples freeze embryos for the second child while they try for the first child naturally after a couple of years. Say a 32, 33-year-old lady comes and she says that, we don't want a child for the next 3 years. Ovarian reserve is like borderline, maybe 1.5, 1.8. But we want two children, but we don't want them before 2 to 3 years. So please freeze our embryos, and maybe after 2 years we will try naturally, because we always tell them that low AMH doesn't say that you will not conceive, you're still young. So they said, okay, we'll try. If we don't get pregnant, we'll use those embryos. If we get pregnant on our own, we'll still want to have these frozen embryos for our second child. And it would be strange to know that some newly married women opt to freeze half of the embryos and freeze the other half as eggs to preserve their reproductive autonomy. They're not sure whether they're going to be with their partner after 5 years or after 10 years. And so they say, freeze half of my eggs and freeze half of the embryos. So social egg freezing, is it hope? Well, it is generally well received, mostly by single women who wish to buy time before starting a family. Our study showed overall positive attitude towards social egg freezing for women of all ages, most not regretting the experience. It is the only way at present which enables career-oriented women to have a reproductive autonomy. Or is it hype? Age is an important factor. A woman of 40, when she preserves 10, 15 eggs, I don't know whether she will have even one embryo which would be worth giving her a live birth. So it is important to undergo this procedure at the right time, otherwise maybe a false sense of security. The oocytes may not be enough to make adequate embryos leading to a live birth, that I just told you. The pregnancy rates would follow how robust the center vitrification and post-thaw survival of oocyte is, and the present pregnancy rates of the center. I mean, if they make their blastulation rate is good, they would have a good number of embryos. But if the blastulation rate is poor, they are used to transferring day 3 embryos, day 4 embryos. Those are not the right centers where one should freeze embryos. Uh, I don't know how to stop the WhatsApp calls. What do? I put it on airplane mode. Still the WhatsApp call is coming in. Why is it happening? Anyone can tell me? Anyways, where is my presentation gone? Is my presentation still visible?
Yes,
Yes,
ma'am,
ma'am.
it's visible.
It's visible. Where is it? There was a phone which came in. I put my phone on airplane mode, and yet the phone just disconnected everything for me,
It's showing that slide of hope and
showing my slide. Which slide is it showing? The last one?
Ma'am,
hope and
now it is not visible. It has come back.
It has come back, right? So, I just thought I would tell you this, thank you. And then I thought that, you all are very inquisitive minds. You'll say, ma'am, how do you do random start? I want to see the chat box if anyone thinks, because then I brought in a few cases where we did a random start in cancer endometrium stage 1A, medically reversed with Medral, medroxyprogesterone acetate, with 2 endometrial biopsies negative, diabetes mellitus type 2. Do you want to know these cases, how we did a random start?
Yes,
I,
ma'am.
huh?
Yes, ma'am.
There's a little time. I thought I could bring in these 2-3 cases where we did a random start, and you would see that the aim is to keep the E2 levels to less than 200. And this was a 32-year-old girl with a AMH of 2.5, 75 kg. We gave her letrose 5 milligram, FSH 225. And in 10 days, final T2 was only 95. Can you hear me? Can you hear me?
Support team, please mute everybody except the speaker.
And if you see, we still got 6 oocytes. Here is a case sheet with a E2 of 95. And here, one of my consultants added Minotask because she thought the E2 is so low. Something is wrong with this patient, not taking into account that we had given her letrozole to keep the E2 levels low. However, with whatever we had, we did get 6 oocytes only and 4 good blastocysts. And look at the previous IVF outside which she had, where no letrose was given. Gonalef was given 450 units on a daily basis. The final E2 was 2,940. This estrogen for a patient who's been treated for cancer endometrium can be something which can reprecipitate her cancer. It should not be done. Now, this is regarding letrozole. This is not random start. This is again breast cancer, estrogen sensitive with ER/PR positive. Again, here, if you see letrose 5 milligram, Gonalef 225, and we continued and we got final E2 as 153, 16 oocytes. So with 16 oocytes, our final E2 was 153 and we got 4 good blast here. You see the E2, I have highlighted that. Now this is another one. She's awaiting chemotherapy post removal of right etinexa for endometrioid adenocarcinoma. And if you see here, AMH level, aim is again to keep the E2 levels low. And this is random stimulation, which was started on which day, if anyone can see. Well, she was started and we gave her letrose and Folisurge 300 units. E2 was 129. So somewhere in the middle of the cycle, she was started. LMP should be here somewhere. LMP is 11.4 and she was started on 24.4. You see this, that she was started on 11, so 21, maybe on the 15th day. And she was taken on letrose with antagonist protocol. And she did very well with her E2 levels also. Final E2 was 214, 8 oocytes, 1 GV, and 2 average blastocysts were stored for her. Day 6 vitrified, 2 average, grade 4 AC. So our main aim is keep the patient safe. You can do her IVF, you can preserve her embryos or oocytes, but she has to be kept safe. So this is a final E2. Now look at one thing which was a learning curve for me. And here AMH was 3.5, 36-year-old, 67 kg lady with a BMI of 27. We started her stimulation on LMP was 12.4 and we started her stimulation a little late, 17.4. This was a random start on day 6 for invasive ductal cancer breast. On day 6, when we started, everything was looking okay. But as we called her after 5 days of usual stimulation, we found a 20 follicle jumping out on day 6 and her LH was high. And another mistake which we did was we gave her letrozole only 2.5 milligram daily. So what happened to her E2 levels? See, they've jumped up to 537. Her AMH was high. So this was in any case a high dose for her, Folisurge 225. Letrozole was low and hence we could not keep the E2 under control. After that, and then as soon as the LH surge happened, instead of antagonist, we changed her into a PPOS protocol because if you see, progesterone rose for her. This surge happened. Next day, progesterone rose. We kept on giving her Folisurge, but we gave her medroxyprogesterone acetate, 1 tablet. We also increased her dose of letrose to 7.5, but we could not control her E2 because we were too late in increasing it. If you see, this is how FSH 5 days, E2 537, LH surge happened, increased letrozole to 5 milligram on day 6 into 3 days with no reduction in FSH dose, another mistake of ours. And the E2 went even higher. We increased letrozole to 7.5 for 2 days, and yet we got 19 oocytes. She was a high responder, and we got only one top quality blastocyst. So these were our mistakes in this, and we always learn for our mistakes. So we don't start any case with letrozole 2.5, and especially if she's got a high image, our dosage should be low for gonadotropin and the letrozole should be higher. That is all I think I have to share for today. We can have questions if any.
Uh, good, good evening, ma'am. Ma'am, this is Dr. here. Ma'am, I wanted to ask one thing. In your third case, which you showed about day 15 from menses for random start, in ma'am, there was written a hemorrhagic cyst. So for that, what I gathered from it is because ruptured follicle.
Yes,
So
ruptured corpus luteum. Yeah.
yes, that's ruptured corpus luteum. So ma'am, it was not triggered by you. I just wanted to know that whether
No,
you
it was
had
not
given a
triggered. She just came. We found a ruptured corpus luteum. We would do a progesterone for her. If progesterone has started rising, then she is in the luteal phase. You can start stimulating her. You can control with antagonist or medroxyprogesterone or tufilzone, whatever is your choice.
Yes, ma'am. That's the only question, ma'am. Thank you. And
Okay.
ma'am, very nice presentation, ma'am. Really
Thank you.
inspired by it.
Thank you. Who was this who asked the question?
Ma'am, I was Dr. Hiyalual, actually came from my husband's phone, so that's why the name reflected is different. I
Ankush
myself,
Goyal.
yes, ma'am. I'm really sorry, ma'am. It was just
No, no, it's
by
all
mistake.
right. Why should you be
Okay.
sorry for this?
So, no, this. Okay, ma'am. Thank you.
Any other questions?
Dr. Basima wants to ask one of my IVF patients, younger sister, 17 years, has low AMH 0.6, and her mother has history of premature ovarian failure. Can I advise her oocyte preservation?
See, look at her antral follicle count. A girl who's 26 and has a 0.6 AMH,
17 years, she's written. 17.
17 years. See, she's too young to have oocyte cryopreservation. You have to make her prepared mentally to give her HRT once she goes into premature menopause, get her karyotype done, get her fragile gene tested. Um, what is it?
Fragile X mutation.
FMR gene mutation tested. See what is leading to such a low AMH at 17 years of age. So karyotype is important to see a mosaic Turner's. Fragile gene testing is important. Then autoimmune, we have very few tests, but you can do a adrenal antibody test, and if that is positive, then also you would get an idea. Please do her FSH E2 on day 2 to know that is her FSH unusually high already or is it normal. So for a 17-year-old, you can just sort of reassure, counsel her that later on she may have difficulty in reproduction, but she's too young. What is everyone's opinion? Should we go for oocyte freezing? Because we wouldn't get more than few oocytes if she already has a AMH of how much did you say?
0.6.
0.6. So if she's got a good AFC, a lot of women with 0.6, 0.7 may still have a AFC of 8 to 10. When she's unmarried, is she
Ma'am, her AFC is only 3 to 4 both sides.
all together?
Each side 3 to 4, and she has got irregular cycles. Alternate months only she has got cycles now.
So now what you do is whenever she has a cycle, please do a day 2 or 3 serum FSH and serum estradiol. And if you find the FSH is already going above 25, then there is no way you can do a good oocyte cryopreservation for her. Just counsel her, uh, keep her sort of um, socially aware of her situation, and you can always if she gets very irregular periods or stops, then please go for HRT where you can give her estradiol 2 milligram every day and give her you can give her dihydrogesterone for 14 days, maybe 5 milligram, 10 milligram tablet for 14 days. So this is the regime which we follow these days. Either we give gels to these girls or tablets, and something like progesterone or hemisuccinate compound of estradiol are good. And I thought that 4 milligram is essential for very young girls, but I had attended a meeting just now where they said even 2 milligram works very good for them. So please don't prevent her from taking HRT if she goes into premature menopause. But then her reserve is already too low. Investigate her for the reason why she's gone into this.
Thank you, ma'am. Her FSH I did, it is normal, but E2 I didn't do.
No, it is very important. You will find the E2 like 200, 300, and FSH like 6, 7. And you'll think, oh, she's not going into premature menopause. Give her some withdrawal bleeding and then do a FSH E2 again. And you'll get the correct FSH and E2. FSH alone may not be enough in some patients who are menstruating off and on. It may be good if she stops menstruating for 6 months or 4 months. Then you can still do FSH alone. But if she's getting menstruation every alternate month, then do both the test.
But ma'am, should we not do a preservation if she's not a Turner's or something? Should we not go for a freezing for her if her FSH is not bad? But this is the only chance, I believe.
So what you are saying is also right. Depends on how conscious a 17-year-old girl is for her fertility, future fertility. And we cannot impose it on a 17-year-old girl. We must investigate her much in advance first. So I think her karyotype is very important. Her Fragile X syndrome ruling out is very important. It's important to rule out if she has an autoimmune condition. And if she has any of these, I don't think she's going to last long. And already, who was it who said that she's already started menstruating less often, once in 2 months?
Yeah,
Yes, ma'am, she's getting
Dr.
only
Basima.
once
Yeah.
in two
So
months a
in
day.
such a girl, if even if there are, I have had a girl where she came to me with a very low AMH, say of point 0 something, and when we did her AFC, there were two AFCs in both the ovaries, and I told her, see, you are not fit for oocyte cryopreservation at this age because we would not be able to get 1 or 2 mature oocytes from you every time. How many cycles will you go through at this age of 30? 10 cycles, 12 cycles, and then she tells me that, oh, I just had one cycle at Cloud9 and they've frozen eggs for me. I said, how many? She said, one. I'm like, exactly, this is what I'm trying to tell you, that for every cycle you go through, whether you give minimal stimulation, low stimulation, high stimulation, you're not going to get many oocytes, not more than 1 or 2 at the average, Anupma. So, I mean, do you think it is worth it that she goes through 8, 10 cycles to preserve 10, 12 eggs?
I get your point, ma'am. There's
And
another.
that is the only thing. And if her FSH is already high, with E2 being normal, that is very important. If E2 is very high, then it suppresses the FSH and you don't get the correct FSH. And such patients do have a high E2 at times because they keep having premature follicle selection because the ovaries are sort of failing. So do that, do all her investigations. If she still understands the worth of oocyte cryopreservation, then tell her that she will have to go through maybe 4 cycles of preservation if she has 4 to 6 antral follicles on both sides. And even if on average we can freeze 4, I would want to preserve for her at least 12 oocytes to think that she may have 2 good blastocysts.
Ma'am, good evening, ma'am. Yukti here, ma'am.
Yeah, Yukti, bolo.
Yeah, ma'am, I just wanted to put a point that I think she should meet a geneticist also because she's such a young girl and she is already having the POI. So before going ahead with the oocyte cryopreservation, she should take a
You
geneticist
probably did not
clearance,
hear
ma'am.
that I already advise a chromosomal analysis for her. The FMR gene mutation has been advised, the autoimmunity testing has been advised. Unless all this is done, what will the genetist do? Will also advise these tests only. Na? There is no other test which we can do to see what genetic condition. So this is what I'm saying, that she should go through all these tests. It may take 1 month. She may have the FSH-E2 also done on day 2 by giving her a withdrawal meprate if she goes for longer periods of amenorrhea. And then if it appears feasible, then only she should go for oocyte cryopreservation. Even if she's a Turner's mosaic, we can always preserve her oocytes if she so desires. But then she has to know that one cycle will not be enough for her.
Okay, so for even for Turner's mosaic, we can preserve it.
Yes, yes, you can preserve. For Turner's mosaic is the only condition where they can have a pregnancy. You can preserve the oocytes, provided she has adequate reserve at the time when you're looking at her. Maybe if her AFC was 10 on both sides, I would have said 2 cycles of stimulation and let us preserve 10, 12, 15 oocytes for her. But then later on with her partner semen, how many embryos she make, how good is the IVF center, what is the blastulation rate, everything will convert these oocytes into live births.
There was one more situation, ma'am. I'm in a small city and I keep seeing patients who come and inquire about this, but many of them are still not sexually active.
Yeah. So
Unmarried.
that doesn't matter. All these girls who come for cryopreservation, 50% may not be sexually active. They have a abdominal ultrasound, but when they go for retrieval of oocytes, they give a consent that they are ready to have a vaginal retrieval. And today girls understand that there's no such thing that your hymen is ruptured, so you can't get married or you can't.
So, okay, so it's not a problem on our part that we can go
We
ahead.
can take them, of course, but we have to tell her that we'll have to go vaginally, and she has to just consent that, yeah, I'm ready to have vaginal retrieval of oocytes because most of these girls are unmarried and 50% may not have been sexually active earlier.
And if they're of the age less than 21 still, we can go ahead for social egg freezing.
वो आप पता करो ना ART लॉ कितना सोशल एग फ्रीजिंग के लिए ART लॉ से पूछना होगा दे हैव नॉट डिफाइंड एनी एज फॉर social egg freezing. So if a reserve is going down, then only a 20-year-old will come
Yes,
for
yes.
social egg freezing. But if a reserve is okay, she won't come before 30 years of age, right?
Yeah.
So if you found a low reserve, then it becomes like a cancer patient where you have to do a preservation of oocytes, and we've done it for 15, 16-year-old also.
Thank you.
So I think we can do it, even if she's of a low age, but she's menstruating, she's ovulating. Similar to what is everyone's opinion? Tell Anupma, what is your opinion? What is Dr. Bhavani, Tejasri, Yukti?
Ma'am, 21, the age where ART law applies for the female, 21. So
That
I
is for
think maybe
ART.
that.
That is for ART. For
That
oocyte freezing, especially if it is a medical reason, any age should be good. We do freezing at 16 years. हमने 15 साल की बच्चियों का freezing किया हुआ है. She has to go undergo cancer treatment now. In May, we won't freeze her embryo eggs in April, whether she's married or not. If we don't freeze her eggs at the age of 16, 17, when will she have that? She's going to undergo chemo or maybe radiotherapy. So I don't think they've defined any age. Tell me, someone tell me.
Ma'am, they have not defined. I am the appropriate authority in my state, and I know this question once cropped up. But I said, then when they asked my opinion, I said social egg freezing would never come. Only the medical reasons. The patient actually was of endometriosis patient.
Correct. So even that is like low ovarian reserve, right? Ovarian, if she's got endometriosis surgery or no surgery, she has a low reserve. She will equal to this girl who's come as a 18, 17-year-old girl with low AMH. Right, Anupma?
That is why I said I am okay. I mean, you should go ahead. That is what my answer was.
So what is everyone's opinion? Tejashri is here. Bhavani, are you here?
Yes, ma'am.
What is your opinion that if a 17-year-old comes with a low AMH, this is a medical emergency to preserve her oocytes?
Madam,
Yes, ma'am. If there is a medical condition,
No,
definitely.
there's
But
no medical condition.
if
Maybe
then, yes,
found
ma'am, but then proper counseling because she will need multiple cycles with such low AMH and
correct. This is
AFC.
agreed,
So
multiple
at this
cycles. And
young age, whether she'll be able to take so many cycles because there's
plus,
no point in undergoing just 1 or 2 cycles
correct.
and
Plus
getting this.
another thing, 10 years ka, to we know that it is for 10 years. We don't know how good the oocytes will be in 20 years when she really, at the age of 30, 31, want a child.
Ma'am, I have a question regarding these young age
Let's sorting. Bolo, who's that?
stimulation. Ma'am, this young age ovarian stimulation, I have a question regarding the increased exposure of estrogen for these
नहीं,
young
कुछ नहीं.
girls.
You can
कुछ
give
नहीं हो.
letrozole. Please don't worry about the estrogen.
Okay,
This
ma'am.
is her AMH is so low. How many follicles and how much estrogen will she make?
Hmm.
So don't worry about that. My only thing is that I think it should be allowed if we think that the reserve is low or she has a medical condition which makes her reserve low. I mean, medical means something like endometriosis or autoimmune disease or diabetes or anything. I want everyone's opinion on this. How many people think that yes, don't look at her AMH, just think that a
Good
7.
evening, madam.
Yes, who's that?
Madam, I think we cannot do before 21.
No, that is
If,
for
if
a
AMH
baby.
low also, we cannot do before 21.
No, that you are wrong in that because for
We
cancer,
actually how
people,
many times we will ask them for the age criteria? They are writing before 21. You can't do anything. So
I
we
think
and they have not mentioned about the freezing age or outside special freezing like that.
when they've not mentioned,
So
then we can definitely freeze. If they had mentioned the age for oocyte freezing, we would not. And if she's a case where we want to give
but
chemotherapy,
as such,
radiotherapy,
madam, it is a ART procedure, no, madam.
No,
Oocyte
no.
retrieval is also a
no, no,
ART procedure. We
it is
cannot deny
ART,
that
no.
it is not
It
a
is
ART
fertility
procedure.
preservation.
So
It is
I
not
think if
ART.
you will do, I think if you will do, you have to take a special permission from them. Then only we can do for our safety concern.
I don't think if we can write that this is for fertility preservation. It can be done whether it is for medical reasons, malignancy reasons, or a failing ovarian reserve. I would do it for her. But I don't know. Maybe everyone would have a different opinion. But here with this low AMH, this is true that multiple cycles are very illogical for a 17-year-old girl. Basima?
Ah, yes, ma'am.
You feel that, how many will you take out? With 6 antral follicle, maybe 4 oocytes, if 3 are
For
mature, how many cycles will you do for her? You cannot do too many unless we start doing ovarian tissue cryopreservation, which we are going to start. One of our fellows have gone to do a ovarian tissue cryopreservation to Japan, and I'm inculcating her into my team for this. So possibly after 6 months, we will have an answer that can we do ovarian tissue cryopreservation for this girl. Laparoscopically, we take out a part of her ovaries and keep it stable where it is and then reimplant it. I don't know. I have no answers to this question right now, whether that will work or no. I want everyone to opine. This masterclass is going wasted. I will not learn anything if you all don't tell me what to do.
what isn't parents' consent is required in such case?
What are the other questions, Bhavani?
Hello.
Tejashri, what are the other questions?
Ma'am, the next question is uh, somebody has asked that in endometrial cancer survivor patient, on start, we have to check estrogen level and how frequently we have to follow the estradiol levels.
Same as you, if you're doing a IVF cycle and if you are starting on whichever day, just look at the estrogen level, give her a good amount of letrozole, and make sure that estrogens don't rise more than 250. And you can do it the same way, 5 days gonadotropin, call them for a ultrasound and a E2 and a whatever review you like to do. And then again give 3 days or 4 days and then call her again. You do it exactly the way you do other IVF cases. And the level of estrogen during stimulation should ideally be less than 250.
Hello.
There's a
Or
que-
you have to finish.
Hello.
there's a question that when can we start ovarian stimulation in a patient who has just ended her ATT?
Just check her liver functions, and if all is well, then give her one menstrual cycle where she has a lot of salads and she runs a lot, she drinks a lot of water to wash away all the ATT from her system, and then you start ovulation induction in her.
Dr. Shipra wants to understand the PPOS protocol.
You tell, what do we do? We do
So
it for all donors also, and we do it for duostem also.
yes, so there are two ways of doing PPOS. One is the fixed protocol where we start from day one. We start medroxyprogesterone 10 milligram once daily from the first day of stimulation itself. And there is also flexible PPOS protocol, which we have tried in few patients, and it has worked that when uh, we check after 5 days if the lead follicle is more than equal to 14 then also we can start the medroxyprogesterone 10 milligrams once daily till the day of trigger.
What is the benefit of starting late and early?
Ma'am, no benefit as such.
No, there is a
Even
benefit.
even there
Why
is
do you think?
lesser maybe lesser suppression, because sometimes we see that
Yes.
with starting from the first day of stimulation, the LH sometimes gets over suppressed, and then uh, sometimes we have a
Expression
concern
doesn't work very
regarding
well.
the efficacy of agonist trigger in these patients.
Yes, yes. That is why we've started starting sometimes later, so that LH doesn't get suppressed and agonist trigger works. Because in donors, we use only agonist trigger, either antagonist protocol or PPOS protocol. These are the two protocols which we use over there, mostly PPOS. Kriti Singh,
She wants to know the oocyte recovery rate post-thaw and the embryo utilization rate.
who's Kriti Singh? I want to see which Kriti Singh is it? Are you our Kriti
Hi,
Singh?
ma'am. Good evening. Hi,
लखनऊ
ma'am.
से
Good
तो
evening.
बोलती क्यों नहीं हो? I'm so
No, no,
happy
ma'am.
to see that you are
I,
attending the class.
uh-huh.
Hmm.
Yes, ma'am. So, ma'am, I just
Amrina,
wanted to know at SGRH, what is our oocyte recovery rate post-thawing?
98%. 98.
Okay. And, ma'am, the embryo utilization rate?
Tell Bhavani बोलो क्या है embryo utilization rate?
Ma'am, that again depends upon the age, like you said, na, that depending upon the age, she has frozen her eggs. So, depending upon that, the embryo formation rate, utilization rate, everything will depend
The
upon.
embryo utilization rate is the embryos which can be frozen, right?
Right.
So,
Right.
So
so the
here
only the good quality
embryos
blastocysts
are,
are frozen.
yeah.
Yeah.
So if you may make 5 blastocysts, but you find that 1 or 2 are like CA or CC, you will
Hmm.
not freeze them. You will
Yes, ma'am.
only freeze
Hmm.
the A's, the B's, and the C if it is the trophoectoderm is C and the inner cell mass is A, right? So
Yes.
that is embryo utilization rate. And in these girls, we thaw few sites at one. Say 2 straws, 6 sites thawed, and we make embryos. If we make more than one, then we have to refreeze one embryo and we implant one. This is how we go. They only come when they want a child, and we uh, thaw them and fertilize them on the day they normally ovulate. Say maybe you had
Right.
recovered the oocyte today, then it will be today morning that they will be thawed and fertilized. Got it?
Yes, ma'am. Thank you.
You're welcome.
Is it important that it should be frozen only 10 years? Is there a rule that also?
No, no, there's no rule for that, but this is fertility preservation, no? So they are all already frozen. So when you thaw them, we normally thaw them when we are going to do one at least fresh transfer for that woman. So we follow her cycle and we see if she's on a HRT cycle, the day we add progesterone, that is the day we will thaw her oocyte, we will fertilize it, and 5 days later, we will put in the embryo. If you want to put in one embryo and she makes one, it is very good. If she makes two and you want to put in one, then you will have to refreeze or you will have to freeze the other embryo, unless you are putting in two embryos together into her. Understood, Anupma?
It's fine, ma'am. I'm talking about the eggs which we have frozen. The maximum duration is only 10 years for the
It
egg.
is, yeah, as per now, how much is the maximum duration, Tejashree?
Ma'am, it is 10 years only.
10 years.
हाँ अभी तो
That's
10 years ही है because
it's for the eggs as well. That is what I'm asking. I mean, for
I they I'll tell you ART law does have flaws, and especially when it comes to third party reproduction or such cases which are out of the normal league. So such cases are out of the normal league, like donor eggs and like surrogacy. So the other day we were having a class on surrogacy, and is Vijeta here? No. we had pointed out three important pertinent points which should go into the ART commission to understand the authority to understand they need to make these changes. Same way, this is all out of the league of normal ART, whether it is third party or it is oocyte freezing. So there are no laws which are outlined for these yet. What I couldn't understand the question which you asked, Anupma, that should we always use frozen? No, we can use fresh oocytes also.
No. That my question you answered, ma'am. It was just that can we freeze our eggs beyond 10 years also? Because
That we don't know. We would never thaw them, but how safe they would be to, make embryos and not have any defects in the baby. This, I think, we need to look into literature. All of you look into it and look into the world literature that anyone has used eggs which are more than 10, 15, 20 years old, frozen eggs.
I think there is a clause in the ART law that it is 10 years, but under special situations such
Permission
as
you
for
can
medical
increase it.
reasons,
I agree. In special
appropriate permission के
circumstances,
साथ it
correct.
can be extended
Yeah,
also.
yeah.
Extended.
Maximum age for egg preservation, any age. Even at 45, you can preserve, but they won't work.
Someone has asked if pre-treatment we start COCs, then
Pre-treatment,
is the stimulation dose higher?
No.
If
See, there was a lot of stigma attached to COCs earlier because fresh transfer was mostly undertaken. Only in that we thought that pregnancy rates were lower. Now with COCs, when we are freezing oocytes, even if progesterone rises, COCs are given. Your cohort may change, but your embryo quality doesn't change if you've used COC beforehand. What is other people's opinion on this? All are well-read people. I would want you to give your opinion.
Madam, I have a question that in one straw, how many oocyte we can freeze?
3 to 4.
3 to 4.
Yes.
Or like embryo 2, how we are doing like that, 3 to 4 only, not
3
more
to
than
4
that.
eggs. Yeah, because at one time you will thaw 3 to 4 eggs to make an embryo. So if the girl was young, you might even just thaw one straw. Otherwise, you may need to thaw 2 straws. In our place, we freeze 3 embryos in one straw if we have more, and we thaw 2 straws always to make embryos for them.
Okay, madam. Thank you, madam.
there's a question in survivors of endometrial cancers, how do you start estrogen if planning embryo transfer?
No, we don't give estrogen. Survivors of which cancer? Endometrial cancer. I would go for a natural cycle if she's ovulating, or maybe a slightly stimulated cycle if she's ovulating. Electro-stimulated cycle. What would you all do? Tell me. I want to know other people's opinion in this. Would anyone want to give her estradiol tablets for frozen embryo transfer?
No, only letrocycle.
Only letrozole, or if she's ovulating, then a natural cycle.
Madam, if she is not ovulating, higher age, that is
Higher age, if she's not
donor cycle,
ovulating.
she is going in donor cycle.
If she's going for donor cycle, then you give her HRT, but give her letrozole so that the estrogen levels remain low. Maybe it will work.
Along with HRT, letrozole.
I really don't know, but you can try and see if it keeps the E2 levels low and still builds up the endometrium, which it should. Theoretically, it appears. What is everyone's opinion on this? Very good.
Letrozole means what you told, 5 milligram or 2.5, madam?
I don't know. I've never given. Please, everyone,
Okay,
opine on this. I want
Ma'am,
everyone.
can we think of a
Go ahead. Someone speak on this, that endometrial cancer treated patient who's had donor oocytes and want to go a frozen embryo transfer with donor egg. How do we prepare her endometrium if she's not ovulating? If she's ovulating, there's no problem. You can go a natural cycle. If she's oligo-ovulating, you can give her a letro cycle. But if she's
Transdermal estrogen might transdermal estrogen.
And then
transdermal will also have
transdermal, transvaginal is a good option. So these two are very good options, but see the estradiol levels in blood, and if it doesn't rises, I'm very happy with just transdermal estrogen for HRT, and I've given it to a lot of patients. Is that true, Bhavani?
CA endometrium, I don't remember, but yes,
No,
for other conditions, many
we
medical
have given.
conditions, we've given only transdermal.
Yes. So transdermal works very well. You can look at serum levels. Somebody can look at serum levels and tell me if the serum levels don't rise with it. It should be very good option.
Thank you,
Thank
madam.
you, ma'am. We are done with all the questions, ma'am.
Okay.
Thank you for a wonderful lecture, ma'am.
So
Thank you, ma'am.
I
Thank
think the
you.
discussion is better than the lecture. You all bring up such relevant questions that, I have to scratch my brain also. Thank you for joining me. Can we leave now?
Yes.
Thank you. Thank you.
Vishal, thank you so much for
Thank you,
being there
ma'am.
always. Thank you. Thank you. Thank you so much.
Thank you, ma'am. Support
Okay.
team, please end the meeting.
Yes, sir.